So I think we've got now a roundtable discussion, but I would like very much to consider, that all of us in this big room, we are in a round table. So we'll start around here, but please do interact, because obviously we've got lots to discuss. The last 2 years, we've learned a lot about non-invasive ventilation. So thank you so much, Mervyn, for taking time out of your busy day to join us today. So one of the things is about monitoring patients during non-invasive ventilation. And the question is, what do I do? So maybe you want to start saying a few things as just an opening, and then we'll have some questions in terms of the monitoring, patient selection perhaps, and where, location. Mervyn, please.
A, thank you, Luigi. B, hi everyone. C, sorry for being late. I was on call. I am on call this week, and I did a ward round. I came here.
Everyone on an IV.
Yeah, everyone. Actually, one is out. So, yeah, but yeah. So apologies for missing Louise's talk, but I heard you six, and actually very much in agreement. It's a sort of running joke of, I think, medicine. It's art versus science, or art and science. And I think, a lot of people are given NIV as an upper ceiling of care. Well, let's try it, knowing that perhaps they're not appropriate for intubation, ventilation, etc. And some do turn around. In COVID, again, we looked at the data, and 30% of people who were not deemed suitable for invasive ventilation survived to leave hospital. Now, would they have survived without it? Don't know. They weren't randomised into trials, but clearly the clinicians felt that they needed more than just an oxygen mask alone. So to my mind, it's very much a case of looking at the patient. And I think, you six said, you can use ROX index and all of the other scores, but in terms of absolute sensitivity, specificity for that patient in front of you, you're not going to know. And so I completely agree with the point made that you look at the patient, are they tired? Are they struggling, etc., and the response to treatment. And, you try it and see what happens. And you don't leave them too long if they're struggling. And then you have to make up your mind, are they suitable for intubation or not? I think we can, I'm sure, chat about it later, but I think there is a role, certainly in an ICU setting, for anxiolysis, sedation, calming the patient down, because they are claustrophobic. And a personal preference of mine, I don't think it's either or. It's not either NIV or CPAP, or, for example, you mix and match. Same with helmets. Some people love helmets, some people hate helmets. And again, find what suits the patient. And certainly they do get claustrophobic, so you need to give them breaks, etc. So I think it's very much titrating the art combined with the science.
Thank you, Mervyn. One of the things, obviously, I think you mentioned very nicely, the selection process of the COPD patients, not the too severe, not the ones with pneumonia, consolidation. You look at pH, you titrate, things that we don't do in acute respiratory failure. What kind of population do you choose? Obviously, that could be quite interesting. Do you look at PF ratio? Do you look at the chest X-ray? Do you look at... what do you look at?
Yes, it's the answer. Yeah,
all of the above.
You look at everything and then make that considered decision. Again, it's often, sometimes NIV is used as a temporising measure. Often it's used as an active treatment, thinking, well, hopefully we can turn the patient round. Certainly in COVID, with ICUs overwhelmed, lack of ventilators, etc., it gave that important bridge.
To take some time before.
Yeah.
But what I learned with COVID, not to look too much to the PF ratio, because at least at the beginning, we said a lot of patients that with a soft lung, they're not bad in terms of ventilation, in terms of movement of the chest, but with a terrible PF ratio. So some people said, okay, we must intubate because normally we intubate patients with PF ratio below 100, with a FiO2 higher than 80. But these patients were managed very well with non-invasive or with high-flow nasal cannula. So now I'm less concerned about PF. What I very concerned is if the patient is comfortable in breathing, no dyspnoic, the respiratory rate. I try to understand if the patient is auto-inducing ventilator, self-induced lung injury. This is very important for me instead of PF.
Of course, yeah.
I mean, I completely agree. I mean, it's really interesting that a lot of the trials of high-flow NIV CPAP have a lot of crossover within the groups, and clearly the teams have simply looked at the patient and said, "Well, hang on, this isn't working. Let's try something else." That's the first thing to say. The second thing to say is that I've just come back from South Korea, where I'm doing a little bit of work on COPD with colleagues there, and there they don't they only for the last 3 to 5 years started reimbursing for non-invasive ventilation. So the physicians there aren't trained to do it. So the emergency physicians and the respiratory physicians don't do it. So the most experience comes in critical care because patients with COPD, approximately 60% of which are intubated rather than given NIV. So compared with about 4% here, I think, isn't it? Because they're simply not reimbursed. And the fascinating thing is their outcomes are fantastic. And so there's no reason to change. But because it's a publicly funded service now, which it wasn't before, there's now an economic impetus to change to NIV. So it's really fascinating how so many different factors can influence why patients get intubation and whether they do. But junior doctors are simply not trained to administer NIV on the wards in South Korea. That's something
very interesting. I'd like to come back to Mervyn's point about, I think that tolerance of NIV and supporting a patient, especially in acute respiratory failure, to manage being on NIV is a huge thing that is particularly generally falls to nursing responsibility, right? And a trained, excellent nurse who can help that patient get through that fear, that dyspnea, that claustrophobia, will enable better tolerance, and I think that's some of the skill that we're sort of missing a little bit. But we see it in long-term NIV as well. We're highly non-compliant patients because they just don't like it. So I think it's a big thing in terms of ways that we can support our patients.
Yeah, it's fascinating just to come in how many people, when they come back to us for long-term NIV 4-6 weeks after acute events, say, I hope it's not going to be like before. And we have to reassure them that actually this is an entirely different treatment in a sense. When patients are fearful, then any treatment that's perceived as being invasive is unpleasant.
My wish list, if there's any companies out there who make masks, whatever, is wouldn't it be nice to get patient-specific masks, helmets? Because at the moment we have 3 sizes and we have to fit the mask to the patient rather than, fit the patient to the mask rather than the mask to the patient. And, everyone has funny faces. And, if you're lucky enough to have that mask, that suit.
Why are you looking at me?
I just, in a general direction. But it's a shame, isn't it, that we don't mould the mask to the patient.
So what we agree so far,
also the ventilator is important, no? Because sometimes in the ward they use ventilators that are terrible, no? And so I think no high performance ventilator, no gas blender, and so they would. In intensive care is maybe very different, so this might be one reason of failure or success.
So leading to failure, I think what we all agree, based on your talk, what you were saying, and Salvatore, what you were saying, is that non-invasive support has definitely got a place in the initial management of these patients and reduces, averts intubation, although mortality, so as we've discussed. The question, you showed a slide saying that delay in recognition of failure leads to worse outcome. So that's my question. How can we be alert, and what do we monitor to make sure that patients who do need intubation or would benefit from intubation don't get delayed, and then going to the slide that you showed earlier on. What do you do?
Yeah, great question. I think the one question I would ask, because unfortunately these audits don't capture the, oh, well, it's a rescue therapy where the patient isn't progressing and then it's, oh, well, let's try it just to see, rather than delayed recognition, you know. So we don't capture that, you know, sort of protoplasm of the patient, you know. So I agree, it shouldn't be missed. And yes, even, you know, venous blood gases are easy. Blood gas machines are easy to access day and night. And so, as you say, it's looking at the patient and repeating the numbers. And again, just echoing your comments, it's much, much easier on an ICU. You know, we have the resource, the staffing, but if you're a you know, busy, you know, ST whatever on a ward and you've got 20 patients and you're being screamed at by the emergency department, and you know, it can be difficult, and that's the problem with the system, you know. And I think we saw it in COVID too. It's a case of resource, training, expertise, and I think often, sometimes it is belated, sometimes it's, okay, well, they're not doing, let's just try it just to see. And clearly, I think, you know, your sixth point is, you know, if you wait too long, you've missed the boat.
What about you, Salvatore?
I
How do
think
you monitor your patients?
Monitor is clinical at present. One important thing, I think, is there is a paper showing very, very clearly that you have to monitor basic things. For example, tidal volume. No? If you are delivering 10 centimeter of water or support and you get 800, 900 of tidal volume, then it is for sure that the patient is struggling a lot. The inspiratory work is a lot, no? Because you are supporting a stiff lung and chest wall with only 10 centimeters of water, and then you are getting a very high tidal volume. This is a reason of failure, and also respiratory rate. So I think that first of all, there is a clinical approach. Now you must look the patient and dyspnea and paradoxical movement and the sweating and so on. Then the tidal volume must be 6, 7, like the protective ventilation. No, if this exceeds, it means that the patient is making a lot of inspiratory work and respiratory rate. Then we don't have at present a way. I have some experience. We are in a Dräger contest, but I have some experience with the catheter for the electrical activity of the diaphragm, and it is fantastic to say if patient is working a lot, the narrow ventilatory drive is higher, and these patients are going to fail. I have not so much data because it is difficult to convince the doctors to put the catheter in a patient with this already in respiratory failure. But I know there is a fantastic, there is the possibility to have this information from a non-invasive way. So this should be really very important, because I think, I mean, I might be wrong, but all this trial that takes thousands of people, but we must know the single patient, no? And we have some idea of the monitoring of this patient, because patients that work a lot, they are going to fail probably, and the patient that work the right, they are not to fail, maybe. So it is important to monitor all these things.
Thank you.
Yeah, I was just going to come back on that, just with regard to the diaphragm EMG. So I think that there is the big data, but it's really important to understand the individual physiology as well. And we too do our diaphragm EMG, and it's very useful for looking at asynchronies. It's very useful for looking at Wilson breathing.
Not so widespread in clinical.
Unfortunately, so as part of my PhD, I tried to recruit 120 patients and to do diaphragm EMG in 40 of them, and 40 consecutive patients declined.
There is also the possibility
the
to position the old esophageal balloon. No, but this is very difficult to interpret in patients that are spontaneously breathing, because it's difficult.
I agree. So we've got a question. Hi, Tim. Sorry.
Tim Gould, I'm from Bristol. So I agree entirely with what Professor Grasso just said, that knowing how hard the patient's working in terms of tidal volume is key, because something we saw a lot in COVID is with resources, a lot of patients ended up on CPAP and NIV, and it was trying to pick the ones that looked cosmetically better but really weren't improving, and some of them went on day after day with quite good PaO2s and saturations, but they're still on 12 or 15 of CPAP. And CPAP became another problem as to can you tell how deeply they're breathing. So what about measuring sort of negative inspiratory effort? So do you put NG tubes in these patients anyway because of the mask? Can you measure esophageal pressure? And I've seen now that you can measure negative inspiratory effort at the nose.
Okay.
That's right.
And I wonder how many people got experience of that, because I think trying to limit lung damage in people who had prolonged periods of CPAP.
Yes.
In the first phase of COVID, we intubated all our patients very early and had quite good outcomes through the ICNARC sort of data when you review it. In the second phase, we left more patients probably on CPAP for longer, and I'm still not sure that was the right thing to do. We had a very big ward area doing all the NIV and CPAP, and only intubated patients came to the ITU because of the resources. So measuring, quantifying negative inspiratory effort, what's the sort of value of future? Is it practical?
It is difficult to measure with the esophageal balloon because the patient is doing sometimes also expiratory effort, so you have we are not sure that the deflection of the esophageal swing is complete or is due to expiratory and then inspiratory, so is hard. The electromyography is definitely better, and also if they use the expiratory, because with the electromyography you can also have the expiratory trace, expiratory muscle trace. If they use the expiratory muscle, so it is a sign that something is going not so good. But I must say that patients that are doing a lot of effort and they are young, they stay a lot of time, and most of the time in COVID, these patients were intubated and they went to ECMO very fast, because the progression of the lung disease is terrible in this patient, and because they continue to struggle with the non-invasive for a long time, as compared with older people that they get exhausted. So I think that is important to monitor, but we don't have. I say, okay, first of all, let's look to the tidal volume, please, because it is something that is very easy to see.
Can I just check how many people can measure tidal volume in their CPAP system?
No, okay, the CPAP with the ventilator.
Yeah, with a ventilator, but you know, it's quite hard. You can see one or two hands.
Maybe we can use all the things, but we have to experiment.
I'll tell you some.
Electrical impedance tomography and so on.
Nada, would you?
So just a quick observation. I think you guys were making an argument for being a clinician.
Yeah.
And I think that the
Shock horror.
Yeah, exactly. So
That
the studies are absolutely useful, but studies always have exclusions, and if you see a patient, you can't just exclude. So you're stuck with take care of the patient. Yeah. So I think that's a very important thing with non-invasive in particular, because there's a skill to it that comes over time, I think. And if you don't use it often, like in the States, I would say we don't use it often. And so we never develop the skill unless you have a particular interest in it, and then you push for that, and then you understand the subtleties of it, making the patient tolerate it and so on. Like, for example, I still believe CPAP is useful, CPAP on the ventilator, where you can monitor the volumes. Yeah. I don't know that adding pressure on top necessarily for all patients makes sense. There's some really old data showing that the phenomenon of COPD is defending their lung volume. In other words, they can exhale expiratory, and it gives them an inspiratory boost. And sometimes you have asynchrony with non-invasive, so they don't like the flow too much. So it's an individual thing. You're stuck from the world of academia, diluted down to the patient that's in front of you at that moment. But anyway, I think it's important that these, whatever you monitor and so on, like just for example, it would be nice to know the patient's effort and not sort of be lulled to sleep because of the saturation probe or the tidal volumes even, or well, how's the patient working? What muscles are they using? You know, so even though we don't measure these things directly, there are things you can look for that makes the patient, you know, this patient looks bad. It's just a little more abstract, I think, and I think we don't teach our younger doctors, now that I have gray hair, the younger doctors how to you know, look for mechanics, you know, the ones you can see with your eyes.
That's a good
anyway,
point.
Yeah.
I endorse that completely. Again, what we did in COVID was, we had a sort of pop-up respiratory unit where, which was useful because it basically took the pressure off the ICU. But what we did daily rounds, and anyone not looking good, so we tried to keep some beds on the ICU for the ones that weren't coping well. And there was a lot of the time it was just experience. They have a leak that nobody actually bothered to check on. The flow rates. So sometimes flow rates were too low and sometimes flow rates were too high. And again, knowing that you can modulate it to find what the patient was comfortable with. Again, when they were doing, mobilizing out of bed or whatever to try and just sort of compensate for that. So it's that learning thing, and COVID, unfortunately, sort of came too quickly. And, I think the point made, it's that experience quotient about troubleshooting or optimizing. And I'm not saying ICUs are perfect, don't get me wrong, but, they're better because of your point about familiarity.
I mean, one of the things, Penny, could I say this thing and then get back? One of the things we've learned is, you were saying clinical observation. Sometimes you don't need huge amounts of monitoring tool. Yeah. So what do we know? That patients that start breathing high effort, they start having accessory inspiratory muscle. You touch them. If they are contracting, you know what it is. You look at nasal flaring, you look at respiratory rate, tidal volume, expiratory muscle contraction, put an abdomen, and then hand on the chest and hand on the abdomen, see whether there is thoraco-abdominal asynchrony. If you've got all of those, a patient is failing, and I think you can do that very easily. If you've got one or two, monitor. If it's all of them, definitely failing. So there are nice scoring that you can use just by observation and touching a few things. Penny, sorry.
Yeah, Dr. Sue, I just want you to find comfort that it is a global issue of placing a non-invasive mask without a port on a patient. It's not just here, it's global. So we actually have had that happen several times.
They look comfortable after 10 minutes, don't they?
They're so sleepy.
Yeah.
There's a question in the middle there.
Apologies. Please. Yeah, sorry.
We'll just take this one and do a shortcut.
Thank you. So, hi, I'm Stephen. I'm from Malta. One thing that I've come to realize over the past few years is that non-invasive is actually a misnomer because it's more stressful to everybody involved. It's more stressful for the patient. It's more stressful for the nurses. It's more stressful for the doctors involved. So invasive is much easier for everybody. However, I have two small points. One is I totally agree on monitoring. I am here mainly for monitoring because I want to learn more. But I also understand the clinical part. And one thing that is very useful in non-invasive is that the patient is awake and you can actually ask them, are you struggling? This is one of the things that I like to ask them. And if they can't even say yes or no on non-invasive, then it means that basically it's a complete failure. But one thing that I've been noticing in the past over the COVID was that we upgraded our ventilators. We've stopped using the Respironics Piper Vision, okay? And we're using now Draeger machines, Hamilton machines, which are very nice.
Did you plant him?
No. But which give us a lot more information. But I'm very much worried that the performance of a single limb ventilator for triggering, for comfort, for performance, maybe not performance, but was actually better for the patients. I'm seeing much more asynchronies, much more struggling, much more pressure waveforms not being square, but rather upsloping or even coming up like flow starvation on ventilators with dual limbs. I'm not sure if this is something that I might be doing wrong, or if it is we're setting up our ventilators wrong, or if there is something which people have seen
Can I comment on that? Just it's a really interesting question. Well, point. So during COVID, some of you may know, I was involved with like the Mercedes Formula One team and the Ventura. So we sort of refashioned and upgraded a good old-fashioned mechanical CPAP device. And hey, they know what they're doing with flow dynamics, etc. And they were horrified at how poor a lot of the ventilators were. They were horrified how a lot of the circuits, there was a lot of resistance in the circuits, in the valves. And they said, who on earth designs these things? And it was actually eye-opening to me, because you just assume, it's even like, I'm not going to throw stones at Dräger, because I don't know, we don't use that machine, sorry. but
you're counterbalance.
Yeah, counterbalance. But, even tidal volume measurements are plus or minus 15, 20%.
Wow.
And I was like, oh my God, and we accept this, and they said, oh, you should be aiming for 0.1% variability. So it was actually quite staggering, and they're just literally just looking at flow characteristics of the tubing. And because, like, for example, some of the corrugated tubing is actually on the inside as well, and they said, well, that just creates turbulence.
Yeah, exactly.
Yeah, so it should be smooth on the inside. But we just take it for granted. Oh, well, companies make it, they must know what they're doing. Dräger accepted, of course, yeah. Exactly, sorry. But I'm sure Dräger are brilliant. Yeah.
Professor Shankar Hari, Manu.
Hi, I'm Manu from Edinburgh. I think listening to this debate, obviously I'm not a physiologist or a respiratory therapist.
Go on.
Or a physician. No.
He just likes that sepsis stuff.
So I think listening to this, it looks like this is an intervention that would meet the MRC definition of a complex intervention. And therefore talking about this with an interface, bit of patient, a bit of this, without the rest of the things that need to go with it, is that actually a pointless exercise? What you need to do is to think about a trial design that incorporates those elements of it before we go down the route of can we use half a nose to monitor, another half to give NG fluids or whatever. I just wonder, the debate is slightly skewed currently to personalized NIV when we think that it's complex.
I think that's a really good point, Manu, and I think that all of those trials that have recently been published, none of them have any sort of process evaluation to understand, the fidelity of delivery of the intervention, selection of the patients, understanding that contextual influences on what's going on, and none of them are doing that currently.
Yeah, absolutely. Can I add to that? Like with the Recovery RS trial, I don't know if anyone there was involved, but I fought bitterly at the beginning, saying, no, this is not the right trial. It's not either CPAP or high flow or an oxygen mask. We don't do that in normal practice, and that's a pragmatic trial in the true sense of pragmatic. And so to my mind, it's again tailoring the patient. It's not one size fits a third of the patients, and other sides, So that's right. So again, I think I completely agree. I think complex intervention is the key phrase. We often try to sort of oversimplify, perhaps to the detriment of the study.
So one question there. Usually there is complex intervention, then NIV.
yeah. Maybe we just call it complex.
Sorry.
I'm a trainee in London. Just a quick question. On the first talk, when we're looking at NIV and we're comparing it sometimes to intubation, and the sort of outcome measure is avoidance of intubation, I didn't hear in any of those studies they're talking about patient-induced lung injury, and by being so sort of fixated on avoiding the intubation and focusing on the NIV, are we sometimes tolerating very high respiratory rates, tidal volumes that are dangerous to the patient, and that, whilst that might not kill the patient, it might in the long term do them, respiratory damage that isn't being picked up in those studies? And how much should we be paying attention to that rather than just, oh, this patient didn't get intubated?
Yeah, that's a very good point. And I think that's another area with these trials, is that we don't have that longer term follow-up as well, right? We're very focused in that very short term immediate outcomes. and we collect maybe 90-day mortality because it's relatively easy, but bringing a patient back in to do lung function tests later, none of our trials are doing that, right? So it could well be that we are inducing some damage, but we don't actually know in the longer term.
So the Florally study, the post hoc analysis that showed that in the NIV group, NIV failure was associated with the higher tidal volumes, 9 mL per kilogram. So there's a suggestion.
And also there is data, showing that the higher the effort, which is not relieved by non-invasive ventilation, is an early indicator of failure. And not only that, recurrence of the respiratory failure. So patients who get better continue to have high effort, they deteriorate and have secondary injury. So I think that's very important. It might go back to your point about mortality difference between non-invasive and invasive. Nader, sorry to keep you waiting.
Yes, no, thank you. I mean, I wanted to just add to what you were saying, which is that I would like to see studies not trying to force everyone into one therapy or another, but trying to understand who responds. And I think that helps us, because first, in medicine in general, you have to know who you're doing something to, why you're doing it, when you're doing it. All those things are really important. And so the response to an intervention, and so who are the responders and non-responders, maybe just more practical to being more translational to what we do in taking care of patients. We want to know who's going to respond or not. And if we could articulate, who's a good candidate, looking back at who, what characteristics they had, rather than saying, as you said, putting them into CPAP or this or that, and forcing people into strategies where they could actually be better off in this arm, in that arm. And so something a little more practical that's more in tune to the clinical world would be, I think there were some older studies that tried to look at some characteristics that I just haven't seen that more recently. It's all sort of just big number crunching more.
But I agree. During COVID pandemic, we are a lot of patients. Sometimes we negotiate with the patient the kind of interface, because I don't like the helmet, no, I prefer the mask. So it is important that the patient. There was an intervention in the audience, and I fully agree that the patient must be fully cooperative for the success of NIV. So sometimes I have seen NIV applied to patients that are not. Not cooperative, are obtunded, we say in Italian, are not fully agreed. Okay. So this is a mistake, because this patient, maybe they have a problem in maintaining the airways, so some inhalation, and also we cannot have the feedback, if the patient improve, how do you feel? I feel better now. I'm a little more comfortable. So you have to speak you have to continue to speak with the patient, to ask to the patient and to cooperate.
And although I would just say that respiratory drive is not spoken. In other words, if you understand how to be in tune to someone's respiratory drive, because if you can't satiate it with whatever you're doing, whether it's invasive or non-invasive, that's a problem. You're going to go down the path of something problematic.
This is one of the reasons that most patients prefer the nasal cannula, because this way they feel more comfortable.
I feel like we could go on and on forever, can we? But I don't know how many people feel the lack of caffeine coming to the systems. And
with a tight-fitting mask.
With a tight-fitting mask. And perhaps it's time to do that. But I would like to thank Professor Singer, Professor Grasso, Isik, and Luis Ross.